It's Module 2 for History of Technology in the Healthcare System for the Intro to Healthcare Information Technology class of the Certificate Program at School of Continuing Ed. What we're going to do is we're just going to go through a brief overview of the history of the healthcare system. We're just going to go through some main milestones, and then we're going to go through a history of technology. So just like we can see how the two paths kind of collide and where they end up with. Well, basically, back into the late 1800s, we find that the doctors are now going to get organized, and so the American Medical Association kind of becomes more organized around this time, and they become a leading driver in healthcare changes in this country. By 1912, Theodore Roosevelt begins talk of a national healthcare after he had viewed some of the programs in pre-World War I Germany at the time, thinking that there should be a national type of healthcare system. In 1929, Baylor Hospital started a program with some locals teachers union to form the first health insurance. So this was where an insurance, they would basically pay for the adverse events that would occur. But it was all done through Baylor Hospital. By 1931, we start to see that the Farmers Union in Oklahoma starts the first HMO, where there's a flat fee whether or not services were rendered. So this was the first foray into the HMO, like a managed care. Again, the whole purpose was to create quality of care as opposed to the services. In 1932, the Wilburn Commission recommended group insurance at a larger level, which the AMA denounced as a socialist. And again, remember the time frame right after the 1917 Bolshevik Revolution and communism prior to World War II. This was a very tumultuous era. In 1934, President Roosevelt considers putting in national health insurance as part of the New Deal, and he subsequently pulled it out because otherwise his New Deal would have failed. By 1938, early insurance plans find increasing popularity in prepaid services. This was including, again, the unemployed and seniors. Remember, the purpose that we said for insurance companies was to insure healthy patients, not sick ones, and so those were the targets for that. By 1945, Truman touts a 10-year plan for compulsory coverage. He then does it again in 1948, both of which failed to gain any traction. By 1951, now we have 77 million Americans covered by some form of accident and health insurance, about 45% of the population. It becomes so large and so important that the IRS finally exempts certain employee benefits, so this would be one of them. By 1962, Kennedy works to include health benefits as part of Social Security, and that failed as well. But by 1965, we have this single greatest change in the health insurance, in the health industry. Medicare was signed under Lyndon Johnson, and what this did was this would now cover seniors over a certain age and provide them with health care. And if you look actually at a cost curve, which you can find on Google, you will actually see that costs for healthcare increased significantly at this time. And the reason is very simple, is that now there was guaranteed payment for services that were rendered. And so many doctors and suppliers of health-related services would jump into the fray because they realized they were going to get paid. By around 1982, actually, coincidentally, there was changes in the Medicare law which would actually change the way payments were made. Hospitals, for example, because Medicare was going broke by the early 1980s, hospitals would no longer necessarily be paid fee-for-service. They would be paid on a basket of goods, what was called a DRG, or a Diagnosis Resource Code. What will happen is that if you went into a hospital for appendicitis, they would give you a flat fee for treating the appendicitis, and that may or may not include, say, hospital stays. But what would happen is that you would get that sum of money if the patient was treated successfully under the amount of time or under what was spent. That would generate profit for the hospital. Whereas if it was over, the government wouldn't pay. A couple of other things would come a little bit later, like readmissions. If a readmission had occurred for the same disease or a related disease within 30 days, the government would not pay for it, and the hospital was required to actually handle that. By 1988, because of, again, still Medicare problems in the system, for costs, they passed the Medicare Catastrophic Coverage Act, requiring seniors to buy additional insurance for catastrophic illnesses. That was repealed less than 1 year later. By 1993, Clinton works for a health insurance card covering all Americans. That also failed. By 1996, HIPAA was signed into law, and what this did was this allowed individuals to take their insurance from one place to another. So if they were at one employer and went to another employer, they would not have an issue with carrying that insurance. But more importantly, and we'll talk about this later when we talk about HIPAA, it will actually provide us with more security and more rules by what was called Title II, which gave us additional code sets, national provider identifier, as well as providing certain safeguards. And we'll see that when we get to the section on HIPAA. Actually, this slide is actually wrong. It's HIPAA. In 1997, Children's Health Insurance Program was signed into law covering children, so now there were more people that were being covered. By 2003, they closed one of the sections of Medicare that was a big problem, which was the prescription drugs that was signed into law. And ultimately, by 2006, healthcare spending reaches about $2 trillion, 16% of the GDP. And by 2010, we were still hovering around 17-18% of GDP with no reduction in sight. Now, as far as technology goes, modern computing really takes hold post-World War II. In 1951, we have the first commercial computer. By 1953, IBM enters the computer field with its 701 EDPM machine. We then have programming languages starting to be developed, and it was only in 1959 that the first bank industry computer was actually implemented for Bank of America. In the health industry, nothing. Not really surprising, because the health industry would lag for generations, actually. Prior to World War II, in healthcare, healthcare was very personal. There was no requirement for maintaining large amounts of information. The doctor had the little black bag and knew their patients and made house calls. So it was a different time. By 1951, now you had a lot more patients covered by insurance, and medical advances coupled with more patient involvement were making care more sought after. So now we had more doctors, and we also had changes in habits of doctor visits. As government involvement expanded in 1965, developments in treatments expanded since there was guarantee of reimbursement, as we had mentioned. The cheaper technology throughout the 80s and so forth would allow us to explore the use of computers and technology to help handle problems that were facing the healthcare industry, such as recurring illnesses or being able to manage certain chronic diseases. In addition, it would help us streamline things that we were already using computers for, such as billing, payments, accounts receivable, and ultimately back office functions. The primary of interests in healthcare, primary areas of interest, started in the hospital systems and then decision support systems. However, the first real areas in hospital systems were the financial and registrar type functions in hospitals. Then there was attempts at workflow. Clinical decision support would take much longer because of the requirement of processing power, which was not really available at the time. The first healthcare technology, basically the first adopters were around the 1970s. And it was due to the fact that increasing expansion of hospitals was allowed for by the Hill-Burton Act of 1946. By 65, El Camino Hospital in Mountain View, California, implemented TDS, but it wasn't really until 1971 where they had some capabilities of doing more than what it originally had the capability of doing when it was first implemented. By the 1970s, there were really no more than a handful of hospitals with some sort of system, and again, most of them were back office systems. It was really around hospital reimbursement structure where the focus was. Care functions weren't such a priority. The clinical efforts for hospitals were really restricted to tertiary care centers and large government projects. These were like federally funded projects that would receive a large amount of money for development. The care functions that were implemented, there were some of them, but the cost-benefit remained questionable, so advances in that would take decades before you would see any advances there. These types of systems were large computerized databases. These were mainframe computers, and a lot of the focus was on communicating orders. Again, this was where we get into the workflow for certain acute care functions. Reporting results from labs and pharmacies were also implemented into these systems. It was easier to maintain and track. And again, if you think of these types of functions, these are repetitive type of numerical functions as opposed to text or any type of analytical or ambiguous information that you can see, say, with doctor's notes, nurse's notes, or even diagnoses and treatments, which aren't so clear-cut. Healthcare is a dynamic domain, and the variables are numerous. So it's not as simple as a stock trade where you have a price, the amount, and then the stock symbol. It is a lot more complicated for healthcare because of the ambiguity, the dynamic nature of the information, as well as the freeform nature. So large technical firms had developed the first health information systems for larger hospitals. But that wasn't good enough. Hospitals had to bring in individuals in order to develop the systems according to their needs. These systems were not commodities, and that's why you saw health hospitals develop their own IT departments with programming staff that they would acquire from other companies. And it was really driven by financial pressures and the reimbursement system that was in play in the healthcare environment. By the 1980s, corporations began to integrate hospital systems, spawning many other businesses. So what will happen is that hospital systems begin to incorporate and integrate with each other, and software developers are now looking at the opportunities of pulling in data from the various areas. Medicare shifts payments to diagnosis, payment by diagnosis, or the DRG, instead of by treatment, and the private insurance plans quickly follow suit. This was the change that we had mentioned earlier in this module about how the hospitals would get for a basket of goods, say for appendicitis, they would get paid a certain amount and they would be responsible for treating the patient under that amount. Capitation payments to doctors, which are the number of heads that a doctor is going to manage, become more common. PC proliferation makes computing power cheaper and more accessible. Now, as we get through the 80s, we know, especially in the late 80s, computers became cheaper, and it became more efficient and more accessible for doctors to put in a system, at least to manage things like patient workflow and some patient records. This would be later known as the computerized patient record. Computing power for storage in larger systems, mainframes, mini computers expanded exponentially. We know this is Moore's law, that computing power doubles roughly every 18 months. The payers would then now use mainframe systems to expedite adjudication and use analytical methods to create better policies that they would underwrite. Again, the insurance companies would take the risk, so they would basically perform insurance functions such as underwriting policies. It is in the 80s that we start seeing the emergence of decision support systems, whereby systems would take in certain parameters and then provide, say, a list of potential diagnoses. It would make it a little bit easier for the doctors to understand what the symptoms were and give a list of options so they wouldn't necessarily have to look them up. They neglected nursing type support, and these were done more at a higher, you put in items for a diagnosis and then you would get potential, or items of symptoms, you would get a diagnosis and then prospective treatments. And you'll see this a little bit later when we talk about Watson. The smaller providers would also use computers which were task-oriented and back-office work for appointments and billing. By the 90s, clinical systems become more acceptable. Data analytics becomes much more mature for providers, payers, and government. And they will use the data in a lot of different ways. We have more processing power, enabling us to do more analytics. Client-server back-end office systems begin to emerge, so now larger providers or clinics can actually implement a system that would be more robust. Hospital systems that grow larger become more interconnected, and we need to expand our capabilities of these EHR systems to pull data from multiple hospitals, aggregate that data for potential treatments. The Health Insurance Portability and Accountability Act of 1996 would radically change the way insurance companies and providers change the way they do business. Third-party companies now emerge for billing and codification of claims. The reason this is done is because they sense an opportunity of changing the appropriate diagnosis and or treatments so they can get the highest possible reimbursement. These billing companies would then take a percentage of all of the billing, which is how they make their money, is ensuring that they are getting the highest paid treatment for the diagnoses. And in the late 90s, the internet emerges as a force, and it is only tested in certain areas like drugstore.com as an example, but there isn't much on the internet at that point in time. In 1996, HIPAA comes out, and there are two titles to this. We're going to focus on Title II, which define the offenses related to healthcare and set civil penalties and fraud and abuse within the systems. Fraud and abuse has a significant area in health IT because they use health information technology to identify patterns of fraud and abuse. One of the second ones is that they aimed at increasing the efficiency of the healthcare system by creating standards for the use and dissemination of healthcare information. That is one of the critical pieces to this title because it changed the way payers and providers do business by enforcing the EDI standard as a way to communicate. Covered entities such as health plans, clearinghouses, billing services were all going to be regulated by HIPAA rules because anyone who transmitted healthcare data directly related to payments would have to be covered. By the 2000s, we have integration among systems was more prevalent because of the internet and VPN security. EMRs and EHRs begin to take shape. In fact, there are so many EHR and EMR systems that do different things that an organization such as CCHIT, as you see in bullet point 4, become the certification route, a commission set up to standardize how EHR systems were supposed to work. Web-based technologies make applications more flexible and easier to implement. We also see the emergence of medical management systems to help payers and providers manage people with chronic illnesses such as obesity, smoking, diabetes, asthma. Patients use more self-diagnosis tools. One of the slides later, you'll see that Kaiser Permanente had basically done a survey and found that there were over 100,000 types of medical website databases that would provide information on potential treatments and diagnosis. Pharmacies engaged with patients using their retail models. As CVS and Walgreens, for example, become more internet savvy, they take that knowledge into the pharmaceutical realm to bring patients to their site and to their stores and help manage their prescription drugs. We'll also see, from an internet consumer perspective, the emergence of what is called PHRs, or personal health records, where individual patients can manage their entire longitudinal health record. Medicare Part D, enacted by George Bush in 2003, would now change the face of prescription drugs because now those prescription drugs would be paid for by the government for Medicare patients. And as data warehousing and analytics become more mature as a discipline itself, they will now get used by payers, the government, and even hospitals for things like evidence-based medicine, enhanced underwriting techniques, and the ability to assess infectious diseases, say, by the government to look for patterns in care. By the 2010, we now have the American Recovery and Reinvestment Act, which apportioned $19 billion under the high-tech section for electronic health record implementations. What this did was provide incentives to providers and hospitals to ensure that they were going to get money to implement EHR systems. Later on, in 2010, the PPACA, otherwise known as Obamacare, provides implementation for health insurance exchanges in which citizens can purchase insurance through a central system, and this is a major technology initiative. Now consumers can purchase through these health information exchanges insurance. What will then happen is that we need to aggregate this information in a central database. Payers will need to communicate benefit schedules, and consumers will have to be able to look on a website to actually pull that information and make a decision and purchase and pay premiums. IBM's Watson heralds a new era as it basically passes medical school and becomes a certified resident to practice oncology at Sloan Kettering. Watson, the computer that won on Jeopardy, basically was purchased by Sloan Kettering and was able to go through medical school and pass residency and can assist doctors in providing diagnosis for cancer patients. In addition, advances in telemedicine become more pronounced, allowing more mobility for nurses and doctors to provide care. We can actually put medical devices in a patient's home so that they can manage their care, manage their vitals, and that information is automatically sent to the doctors or to a central database that can actually manipulate or change prescribed treatments. The doctor will be able to see those changes and make recommendations based on the vital signs. So where do we go from here? Well, what we're going to find is that there's a more retail-like atmosphere, especially on the internet. This is called consumerism. There's evidence in the pharmacy arena, including pharmaceutical benefits management and emerging patient technologies. They're always looking to enhance their industry. We'll also see changes in consumer-driven healthcare and personal health savings account, although the PPACA is going to have a significant effect, a negative effect on health savings accounts because of the way the taxable structure is. So we will not be talking about this bullet, but it's something that you can take a look at. The impact will absolutely be significant with respect to technology. We're going to find that there's over 100,000 medical websites out there in some form or fashion. And there are significant benefits to integrating all of that aggregate information in some form to ensure that patients are getting the correct and accurate information. We'll find more remote medicinal practices, monitoring of vitals from remote distances, especially as wireless technologies, wireless communication, and mobile communication become easier and in the hands of more people. You'll have increased collaboration among providers, and we also see this as a form of consolidation in the industry. It will be a lot easier to collect data and take that information, integrate it into other types of care, and deliver more quality of care. So the technology is going to enable us to move data around and have a better picture of the patient's current state than we would otherwise.